Good afternoon from Baltimore, Maryland. This is Dr. Jeffrey Miller, and the title of my topic this afternoon is called the Alveolar Money Shot. I thought of different titles for this short presentation and ended up going with Alveolar Money Shot. Some of the other possible titles were Why Orthodontics is a Specialty Discipline, along with Is CBCT an option or obligation? And the third and final possible title was Why Orthodontics is More Than Being a Clinical Crown Jockey. And those of you who are in orthodontics long enough know what a clinical crown jockey is. There's no reason to explain it. At the end of the day, I ended up going with the Alveolar Money Shot. My name is Jeffrey Miller. I graduated from Towson University. Got my dental education from University of Maryland. My orthodontic certificate from SUNY Buffalo. My board certification in 1991. I've been in private practice in orthodontics in Maryland for over 34 years. I'm a member of the Golden Circle of Excellence through 3M. And I speak on cone beam CT topics related to orthodontics. This case was referred to us by a general dentist down the street who had been treating the patient for a little bit over a year using Invisalign. He called and mentioned that he had not achieved any progress in the case. And this is how she came to us. What he failed to do is ask her the simplest question of all, and that is, are you wearing the trays? And it turns out she openly admitted that she was not compliant, and there was virtually no progress. First thing I did was I got his login and password information, and I took a look at what his Invisalign treatment plan was. It was 15 trays, there was no IPR, and it was a non-extraction treatment approach. He actually used Invisalign Assist to help treatment plan this case. On the left you see the original malocclusion, and on the right is the virtually simulated proposed treatment plan provided by Invisalign. Here's the superimposition. You can see that the case is treated by arch expansion so that they get proper alignment of the teeth. I took a cone beam CT on this patient, uploaded to Orometrics, and Orometrics provides a 3D reconstruction that can be manipulated so that you can simulate different treatment approaches. Here on the left is the CliniCheck, or the Invisalign proposed virtual treatment plan, and on the right is my attempt to mimic what Invisalign had recommended. In other words, I tried to duplicate the ClinCheck treatment plan as closely as possible using the Orometrics software. Here's a superimposition on the left using ClinCheck, and here's a superimposition on the right using Orometrics. With Orometrics, because it's based on a cone beam CT, you can see the anatomy and alignment of the roots. And when you look at that, that looks fine. As you can see, when we add the bone layering, you can see very obviously what the problem with this case is. The roots of these teeth do not align or fit within the alveolar housing. Folks at Orometrics claim that the bone modeling is accurate within 0.2 of a millimeter, and they have data that supports that. However, they show the bone as static. It doesn't show the small changes that occur in the interseptal bone. When you take a look at a sagittal view of this lower incisor, you can see that based on this model, this tooth has probably lost approximately 60% of the total root bone coverage. Now, if you add in the interseptal bone changes, maybe they lost 50% or 45%. Whatever, it's still not a good treatment plan. So why is that? Why didn't those teeth fit within the alveolar housing? Well, here it is. Here is the money shot, or here is the whole explanation for this I would say, poor treatment plan. This patient is a class 2 skeletal with a class 1 dental relationship. That means there's compensations usually in these cases. There's compensations on the position of the incisor as well as the shape or anatomy of the alveolar housing. So when you send a case to be set up through Invisalign or any other of the aligner manufacturers, they are going to set those lower incisors to average clinical crown torques. So that means that you're going to put labial root torque onto this tooth. And if you put labial root torque after you expand the tooth, you're pushing most of that root outside of the alveolar housing. So what would that look like in real life? Well, here's a patient that a colleague from Florida sent me. As you can see, this tooth was pushed past the luminocortical plate. You can also notice that there's been adaptive resorption of the alveolar process, so the possibility to recapture the alveolar housing with the root is more limited now. So the question is, well, why don't you, or why don't we, when we set up the case, tell Invisalign not to put the labial root torque on? Why don't you just have them align it without having the additional root torque so it looks something like this? Well, this still is probably not acceptable. The teeth are still flared out excessively, and there's still increased fenestration, significant fenestrations associated with the positions of those teeth. And maybe it looks better than with the labial root torque, and maybe this would be a better solution if you were to add interproximal reduction. But to even come up with this kind of treatment plan, you would need to know where the anatomy of the bony housing is. These teeth are excessively flared. So without the knowledge of this anatomy of the alveolar housing, you're just guessing at everything. And I do not, in my opinion, I don't believe a cephalometric x-ray is adequate to define the anatomy of the alveolar housing. In this particular case, we ended up treating it with lower incisor. There is underlying bolt discrepancy, and although we simulated different treatment approaches, we end up going with a lower incisor. Here is that patient 1 year post-active orthodontic treatment. Notice that there is no dark triangle associated with the extracted lower incisor that sometimes you see, and that is a matter of closing the extraction space properly. When you take a look at the post-treatment cone beam CT, you can see that the lower incisor from a sagittal view is fairly lined up with alveolar housing, and from an axial view as well. If you take a look and you compare the pre-treatment sagittal view of the lower incisor with the post-treatment sagittal view, you notice that the root alignment comports with the alveolar housing anatomy. But to do that, you need to know what the alveolar housing anatomy looks like. And as I said before, I do not believe a cephalometric x-ray provides that information. From an axial view, you can see here that the incisors are fairly well centered within the alveolar housing, and this patient started with a very limited alveolar housing. There were already some fenestration and dehiscence associated with this patient pre-treatment. Now, if you compare that to a patient that's been expanded, this is a patient, in my opinion, that has been overexpanded to correct the mandibular incisal crowding. You can see how these roots have just been dehisced through the cortical plate, and both these images are taken halfway down the length of the root. Here is the virtual simulation that we did using the Aurametric software, and here is the actual cone beam CT taken 1 year post-active orthodontic treatment, and you can see they're virtually identical. So I guess the message here is, before we drive, we need to know where the guardrails are or the limitations to orthodontic tooth movement, and without cone beam CT, you have actually no way of knowing where those limitations to orthodontic tooth movement are. Thanks for listening. If you have any questions, you can email me at drmiller@orthodonticassociates.com. And if you're interested in joining an alveolar-focused orthodontic Facebook group, please email me if you have any interest. Thanks very much for listening. I appreciate any comments that you would have. Thank you.